Good morning, good afternoon, good evening, wherever you are. Thank you for joining us for this webinar. Thank you so much for joining us for this webinar, the third in the series of webinars by the African Pharmaceutical Forum. The title of our webinar is Expanding Primary Healthcare Services Provision to the Pharmaceutical Private Sector across the region. And you are all most welcome to join us. We have quite a number of people registered for this webinar, and we're really glad to have you. I am Dr. Arinola Joda from Nigeria. I'm a fellow of the Pharmaceutical Society of Nigeria, a fellow of the West African Postgraduate College of Pharmacists, and a member of the Clinical Pharmacists Association. I also currently serve as the Vice President and Treasurer of the African Pharmaceutical Forum. You are all mostly greatly welcome. So just a few announcements as we go. This webinar is being recorded and live streamed via YouTube, and the recording will be made available on the FIP website, on the events website of FIP thereafter, so that you can always refresh your memory and you can always direct other people there if they want information about the webinar, if they want to hear the webinar. You may ask your questions using the question and answer box. It is preferred that if you have a question, you put it in the Q&A box rather than in the chat box, because a lot of welcome greetings will be in the chat box and the question may get buried. You're also welcome to provide feedback to FIP on any of its webinars, including this one, using sending an email using webinars@fip.org. And of course, if you're here and you're not yet a member of the FIP, you're very welcome to join us using the link in the announcements box. So to go on, today's webinar, as I mentioned, is on primary healthcare services provision to the pharmaceutical private sector across the region. And we have, in addition to myself, we have Dr. Elijah Mohammed from Nigeria as our main speaker. He is a consultant with NAEM Consulting Nigeria. We have Dr. Rahanatu Gali Adam, the chair of the Pharmacists Council of Niger, joining us. So we have Ms. Frida Shigweda, president of the Pharmaceutical Society of Namibia, and our president, APF president, CEO, Nufife Avenue Pharmacy, Zimbabwe, Ms. Jocelyn Chaiba, as discussants to the presentation that will be given by Dr. Mohammed. Please sit back and listen and see how we can all improve pharmaceutical practice across the region together. So in today's program, I've already started with the introductions and the housekeeping, and thereafter I'll be introducing Dr. Mohammed to give us his presentation, and he'll be looking at the Nigeria pilot experience, and we're trying to see how and if this can be replicated across the continent. We then have three discussants, as I mentioned, to discuss their comments on the presentation, including feasibility and challenges for their respective countries, Niger, Namibia, and Zimbabwe. And then we'll have an open discussion forum and time to take questions and answer. If there's a bit of time, we may be able to take some open questions on the floor, but it is preferred that you put your questions in the Q&A box. Then take closing remarks by the panelists, announcements, and closing. You are most welcome. The learning objectives for this session, we're expecting that participants at the end will be able to highlight the importance of the recognition and inclusion of community pharmacies and patent and proprietary medicine vendors, and they are called different names in different countries across the region. Some call them drugstores, some call them drug shops, as community-level service providers within the framework for community health and the need to broaden healthcare service delivery capacity in each country to meet the universal health coverage. To understand innovative task shifting and task sharing policy and three-tier accreditation system strengthening tools towards the provision of expanded primary healthcare services by community pharmacists and patent medicine vendors. And then we'll be engaging in a panel discussion to learn about current practices and experiences, as well as the new learnings that can be adopted as possible. So I'm just going to go ahead and introduce Dr. Elijah Mohammed to give us his presentation on expansion of access to primary healthcare services provision by the pharmaceutical private sector, Nigerian pilots experience. Elijah, as mentioned previously, is Chief Consultant for NAEM Consulting and is the immediate past registrar of the Pharmacy Council of Nigeria. In addition to his bachelor's degree in pharmacy, Elijah has an MBA, a Master of Science in Health Management, and a PhD in Health Services, Public Health Policy. He has special interest in health system development and strengthening, health policy development, and implementation. He's also involved in private sector market facilitation and involvement in healthcare services, health leadership, and management. Please join me as I welcome Dr. Mohammed for his presentation. Over to you, sir.
Thank you very much, Dr. Arinola Joda, for the brief introduction, and good afternoon to everyone, wherever you are across the globe. Yeah, first of all, start with the Nigeria situation, an overview of expansion of access to primary healthcare services provision by the pharmaceutical private sector. The challenges the Nigerian situation has before now, you have the personnel, medical equipment, and medicines are the most significant problems facing the country's primary healthcare services. An estimated 20% of over 30,000 primary healthcare centers in Nigeria is functional. And there is a lopsided distribution of the very few healthcare facilities across the country. The failure of the primary healthcare system have created an overburden on the private health sector and made informal healthcare more prominent. The community pharmacists and the drugstore owners are the first point of primary healthcare for most Nigerians, most especially those in the rural and hard-to-reach areas. And these service providers are popular sources for primary healthcare services, most especially family planning, due to their widespread availability, easy of access, consistent drug stocks, extended hours of services, personal interactions, and lack of consultation fees, which you normally have in clinics and other health facilities. Though the community pharmacies and a significant portion of the PPMVs have health qualifications, many of the drugstore owners often do not have the necessary skills and knowledge to provide these services. Before now, both community pharmacies and patent and proprietary medicine vendors were not formally recognized in the health system, and we are prohibited from offering PHC services, PHC products and services that they are or could be trained to provide. Why the need for drugstores? There's inadequate spread of community pharmacies, particularly in rural areas in Nigeria. They serve as a stopgap mechanism for the shortage of pharmacists in the country. Currently, we have about 35,000 pharmacists against a population of 200 million or thereabout. And the attempt to redress lopsided distribution of very few healthcare facilities in the country, and then to make available OTC medicine, over-the-counter medicines in the underserved, remote, and hard-to-reach communities where you cannot have community pharmacies, hospitals, and even clinics. And also to bridge the gap in the provision of basic healthcare services in these areas, and then to achieve the main goal of the national drug policy, which is to provide adequate provisions, accessibility, and availability of affordable, efficacious, safe drugs to Nigerians. with this backdrop, there is need to really work out ways of providing pharmaceutical services to the entire Nigeria populace. There was a pilot program organized by Integrity, and a survey carried out by them with a proof of concept found out that community pharmacists and drugstores have capacity to provide a wide range of family planning and PHC services than they are currently authorized by law to provide, and that they should be repositioned to deliver expanded healthcare services through training and retraining them, especially in the rural and hard-to-reach areas. There's also need to stratify these drugstores owners according to educational qualification, as it has been revealed that a good percentage of them have up to tertiary level education. This survey was done during the first phase of the Integrity project in Nigeria. Furthermore, majority of these drugstores owners have higher level of educational attainment. And the survey came up with the following reports. Those who have up to secondary education, about 47% of them, post-secondary education, 37% of them, and over a third, which is 39%, reported having received some form of health trainings with training level ranging from one community health extension workers, highest in the number, followed by nurses and midwives, 13%, laboratory technicians and scientists, and even medical doctors, 1%, and others. It was also discovered that about 58% of health service provision, including child-related health services, are accounted for by the private sector in Nigeria, and that community pharmacists and drugstores comprise nearly 40% of the private healthcare sector in Nigeria. And they provide between 15 to 83% of all child health services, depending on areas of their service points. And this percentage is higher in the rural areas and hard to reach. Studies have also shown that these drugstores are the first point of care for majority of Nigerians seeking healthcare services in rural and underserved areas. Therefore, not provision this private sector in healthcare delivery by government is a disservice to the nation. So we need to now look at them very well to go ahead. But however, to get this thing done, because before now, the two service providers were not officially recognized in the system. So in order to get this thing done, there must be a policy development. And the federal government have to come up with this policy of tax shifting and tax sharing. And what is tax shifting? This is the process of delegation whereby tax are moved where appropriate to less specialized healthcare workers. In addition, this reorganization of workforce, along with expanded training and retention programs, can allow a health system to use the existing workforce and ease bottlenecks more efficiently in service delivery while also expanding the workforce capacity. Tax sharing. This increases the categories of healthcare workers who can deliver certain health services. With tax sharing, tax are not taken away from one cadre or set of healthcare workers and given to another, but they are shared across groups. Tax sharing enables low and middle level health professionals to perform tasks and procedures that would normally be restricted to higher level health professionals. Effect, freeing up time for these higher level providers within a health system. And then the tax shifting, tax sharing policy is in line with the goals and priorities of the National Health Policy on Human Resources for Health. Policies imperative. The policy change that help to promote PHC services provision by the pharmaceutical private sector. As I said, the policy of tax shifting and tax sharing has a goal. And the goal is the tax shifting and tax sharing policy aims to meet universal health coverage through the mobilization of available human resources to ensure equity, accessibility, and effectiveness in the delivery of essential healthcare services. And the broad objective of this policy is one, to actualize human resource for health workforce needs of the country in delivering of essential healthcare services, outline the essential healthcare services related tasks that can be performed by different cadres of frontline healthcare workers attending to the health needs of the Nigerian population. Also, to provide a framework for empowering a wide range of healthcare workers to rapidly expand access to essential healthcare services to meet the Sustainable Development Goals target, to promote the best use of competence and expertise of other healthcare workers and individuals to meet the health needs of the Nigerian population. And finally, to promote efficiency, effectiveness, and accountability in the utilization of financial and non-financial resources in scaling up access to essential healthcare services delivery in Nigeria. There were some tools that were also deployed. These are programmatic tools. The strengthening tools developed by the Pharmacy Council of Nigeria and Integrity that helped to promote the expansion in the pilot program was one, satellite pharmacy model. This is a model of community pharmacy aimed at making pharmaceutical services available in underserved and rural areas. Three-tiered accreditation system. This is a system that recognizes the educational qualification possessed by the drugstore owners, which is then used in categorizing them into 3 tiers to help to determine the type of services they can render. And the hub and spoke supervisory model, which is a supportive supervisory model adopted to supervise these drugstore owners in their new roles. What are those institutions that were involved and are still involved in training for pharmacists that help to promote this expansion? Pharmacy Council of Nigeria, which is the regulatory body. Through the mandatory continuing professional development program, a lot of lectures and trainings are being carried out. Another institution is the West African Postgraduate College of Pharmacists. They are involved in certificate courses in related programs. Then Pharmaceutical Society of Nigeria, during conferences, workshops, and their AGM, they are also involved in the various training. Then Association of Community Pharmacists of Nigeria, conference seminars and workshops are being carried by them. And then the Clinical Pharmacists Association of Nigeria, they are also involved in this institutional training, involving them using the platform of conference, seminars, workshops, and clinical meetings. For the drugstore owners, which are the PPMVs, a mandatory 5-week training program that is supervised by the Pharmacy Council of Nigeria at approved college and school of health technology within the PCN trained tutors are carried out for them. And the curriculum has been developed for them to reflect their new roles in the service delivery. And their training involved practical demonstrations and even classes at primary healthcare centers for practical acquisition, practical knowledge acquisitions. What are these new roles of these healthcare workers in tax shifting and tax sharing policy? The roles involve provision of reproductive, maternal, newborn, and child care and integrated management of childhood illnesses, provision of HIV/AIDS care, malaria management, and tuberculosis care, immunization services, starting with the COVID-19 vaccination, most especially with the community pharmacists. And most of these activities assigned to any healthcare workers differ according to the educational qualification and the knowledge and skills acquired through various trainings. There are other overarching tasks of community pharmacists in the tax shifting and tax sharing policies. You have the integrated childhood case management services, community level services, HIV clinical management, which has to do with adherence, HIV clinical management will have to do with clinical consultations, immunization services, ARV dispensing, health information and health promotion, antenatal programs, family planning services activities, and malaria management activities and tuberculosis care. There are some of the scope of the primary healthcare services for community pharmacists and these vendors. These are the selected primary healthcare services, and those that have been assigned officially to them is listed in the presentation. You can see identify, refer pregnant women in communities to antenatal clinic, down to provide provision of a treatment for acute respiratory infection in children under 5 years using the amoxicillin. So checking and classifying of malnutrition and provide counseling for malnutrition, and screen for presumptive TB cases and therefore refer are part of those scopes of the PHC services assigned to these healthcare workers. What is the takeaway from the pilot program? Improved visibility for community pharmacy services. It has broadened the healthcare service delivery capacity of the nation. Routine provision of service data, which can be integrated into the nation's information system. Rapid scale-up of access to quality family planning services and other PHC services in the pilot states. An increase in the drugstore owners' knowledge and skills. Standardized facilities to ensure proper storage of medicines and good procurement and supply chain practices. What are the outcomes from this pilot program? The outcome include: one, recognitions and inclusion of community pharmacies and the drugstores as community level service provider in the updated Federal Ministry of Health National Strategic Framework for Community Health. This has never been before. Now they have been officially recognized as community level service providers. Inclusion of community pharmacies and drugstores reports into the Community Health Management Information System in Nigeria to make their services delivery data visible within the National Health Management Information System. Inclusion of community pharmacies as immunization providers, starting with COVID-19 vaccination, and this is highly promoted by the Association of Community Pharmacists in every of their national conferences in Nigeria. Opportunities for other African countries. In most countries in the sub-Saharan region, similar gaps exist in the pharmaceutical service landscape, like: one, skewed distribution of pharmaceutical premises, mostly found in the urban areas, urban centers, inadequate number of community pharmacists and pharmacies and drugstores, non-availability of pharmaceutical care services where majority of the population live mostly in the rural areas, need to increase access to medicines and healthcare services mostly in the rural areas. It is of note that proximity is an important component of access to healthcare services, and prompt access to essential medicines can improve health outcomes. We want to appreciate the Pharmacy Council of Nigeria, Society for Family Health in Nigeria, Integrate E, for the use of materials in preparation of this presentation.
Thank you so very much, Dr. Mohammed, for your presentation. Very engaging one, I believe. I know that there will be thoughts going through people's mind on, oh, is this possible? Can we do this? So we're just going to go on in the webinar by opening up the panel discussion. So I'm going to introduce our first panelist, from Brahanatu Gali Adam, the current chair of the Pharmacists Council of Niger. She obtained a pharmacy degree in 1997 from Nigeria. She is a pharmacist with 3 key experience levels: first as a hospital pharmacist, then as a community pharmacist, and lastly in international consulting. She accompanied several countries in forecasting and quantification for HIV, malaria, TB, and COVID-19 commodities, proposal writing for about 10 years. She is a member of several committees and regulatory bodies at the Ministry of Health in Niger. She undertook certification courses in project management, healthcare management, and in pediatric nutrition, a postgraduate diploma in procurement and supply chain management, and is now undergoing her MSc in procurement and supply chain. Please join me as we invite Famranatu Gali-Adam to please share with us her perspectives from the presentation, as well as challenges that may make it difficult for Niger to take on any of these and the first feasibility for this happening. Please, you can unmute yourself and go on, man.
Thank you very much, Joda.
You're welcome.
Followed with a lot of interest the presentation of the former presenter. I've shared with you on your WhatsApp my little presentation about expanding primary healthcare services to private pharmacies. Niger Republic is a country that is landlocked. Niger Republic is a country with a landmass of about 1,266,491 kilometers square. So very big country, but most of the population is living at the south part of the country, because more than 1/3 of the country is a desertic area. The population in two was estimated at 25,369,415 inhabitants. It is classified under developed nation with low-income countries about $580 in 2022 per inhabitant. The health expenditure per capita is estimated at $25 in 2020, which represents about 6.2% of the gross national income. The country has a low national healthcare delivery system with only 54.42% of the population being covered. The most prevalent disease responsible for mortality and mobility in the country are the upper and lower disease, cardiovascular diseases, and tuberculosis. The health sector is organized in a pyramidal way. We have the primary healthcare delivery system at the lower level of the pyramid, with 72 integrated health care centers. The secondary healthcare level with 44 health district centers. Then the tertiary level with 2 reference hospitals, one located at the capital city and the other one in the middle south region. 2 national hospitals and 7 regional hospitals. The pharmaceutical sector is organized in public sector and private sector. The public sector there is no enough pharmacists that are being recruited by the government. Most of the pharmacies are in the private sector. We are about 369 pharmacists, registered pharmacies in the country, and more than 270 are in the private sector. That is making it really difficult because most of these private sectors, pharmacies are more than 70% are located in the capital city of Niamey. And as I told you, the country is very vast. So the regions are left by themselves with some places there are no private pharmacies, and the patent medicine owners stores have taken the place of the pharmacies, making the health system really very, very poor. The population is not having access to good quality drugs. The challenges that will make this, how would I say it? The challenges that will make this expansion difficult are, as I've already said, the concentration of most of the private pharmacies in the capital city, the anarchic installation of patent medicine stores, and there is no sufficient pharmacy professional in the country. What are the perspectives? The perspective that we are seeing in this expansion of primary health care services is the expansion of the vaccination administration that can be given to the pharmacy, the private pharmacy stores, especially in where there are authorized and where there are installed community pharmacies with a pharmacist as the owner of the premises. The other perspective is to empower pharmacists and all actors in patient care delivery to be able to conduct a bunch of laboratory tests so that where the population cannot have access to these laboratory tests, they can do them in the pharmacy premises. There was at a time the Ministry of Health that tried to introduce the injection of bisoprostol through to promote it through the private pharmacies. But we don't know what happened. There was no adherence to that project. For the population, it is either the population is not aware, it didn't work at all. It didn't work at all. So the pharmacy practice in Niger is a very challenging environment. And there is a lot of misunderstanding of what a pharmacist is. They don't consider private pharmacies to be part of the healthcare system. So they consider private pharmacies as any common store where you can just enter and buy medicine. This is the real challenge we are facing in this country.
Thank you.
I think what I can say about this topic.
Thank you so very much, Gali Adam. Perspectives are very clearly elucidated, and of course, it's going to be something that will be similar in many other African countries too. And before this expansion happened in Nigeria, a lot of it was also similar with Nigeria. Okay, so let's go on to our discussant two, who will be sharing perspectives from Namibia. Frida M. Shigweda is a medicines information and safety pharmacist at the Therapeutics Information and Pharmacovigilance Center of the Namibia Medicines Regulatory Council under the Ministry of Health and Social Services. She is actively involved with the Pharmaceutical Society of Namibia since 2018, currently serving as its president for a second term and previously as its vice president for 2 years. In her role, she aims to serve the profession, increase its value and visibility, as well as fortify the vital role of pharmacy in Namibia. She also serves on the Pharmacy Council of Namibia since 2021 as a member of the council, and currently in her second term contributing to the Education Committee as a member. Her background includes positions such as consultant assistant lecturer, where she practices her passion for pharmacy education and empowering the future generation of pharmacists. She plans on pursuing a master's qualification in pharmacy administration and regulatory affairs. Frida is committed to healthcare excellence holistically and is proactive and dedicated to professional development, which she hopes will have a positive impact on pharmacy in the country. Please join me as we listen to Shigweda's perspectives on the presentation from the lens of Namibia. Over to you, madam.
Thank you so much, Dr. Joda, and good afternoon, good morning, and good evening to everyone. As was introduced, my name is Frida Shigweda, and in general, I'm just a pharmacist above all the other titles or all the other hats that I wear. I would like to first thank Dr. Mohammed on his presentation and also Mrs. Gali Adam for their perspectives that they shared. And really, I would be repeating a lot of what they said because, I mean, as Africa and as one region, one continent, we generally face similar challenges, as well as we normally are very forward-thinking as to the solutions that we want for our continent. Just maybe to touch on a couple of aspects of Namibia. So we are geographically a very vast country, about 820,000 square kilometers. And we have a population recently just declared a population of 3 million. So we are reproducing quite well because we've been wanting to do that. And approximately the number of pharmacists in Namibia are between 600 to 800. And I really do speak under correction as I don't have the stats for this year. So in Namibia currently, what we are trying to look at in terms of expanding primary healthcare services to the private healthcare sector is something which is already provided for within our current regulations and laws, as well as our national medicines policy. So the laws that allow for not necessarily the expansion of the primary healthcare service to the private sector, but rather allowing for a pharmacist to prescribe certain medicines for certain ailments. And whereas the case in Nigeria is that this initiative is rather being pushed by the Pharmacy Council of Namibia in Namibia, by the Pharmacy Council of Nigeria in Namibia, the difference is that this is being pushed for by the pharmacist associations in collaboration with the University of Namibia School of Pharmacy. So these, along with the academic institution and the Pharmaceutical Society of Namibia, as well as the Pharmacist Care Association of Namibia, they have formed a task working group that is focused to basically just bringing the provisions within the regulations and the laws to life. Since this is something that's already provided for, they decided to take the initiative to basically push it forward to essentially bring to life the fact that pharmacists should be able to prescribe. And the rationale behind this is not only in terms of expanding the role of a pharmacist, but also making sure that the pharmacist's role in expanding treatment to their patients is actually recognized. Also expanding the clinical role of the pharmacists within the country that they have as well. And then especially for such a vast country like Namibia, where no different from the situation in Niger and Nigeria, a lot of the healthcare services are really more in the urban areas because, I mean, people are flocking to those areas for jobs and employment and better socioeconomic circumstances. And then you find the rural areas where there's only one community pharmacy, or where you only have one clinic that is owned by the Ministry of Health, which is the government. And some of these services are simply just are not there. So the aim of bringing these provisions within the Acts to life is also to ensure that all the stakeholders involved are meeting the strategic objectives of the National Medicines Policy, which is to facilitate the availability, accessibility, and affordability of quality, safe, and efficacious medicines countrywide. I think this is, let me say, a worldwide anthem that we sing all the time. So that's something that we can look at. And as a country, what the three institutions now have done, the task working group have done, is that they have developed a framework, basically a training framework for what this prescribing pharmacist would essentially look like. And the focus right now is just on pharmacists, because that is the provision within the Acts. We're not trying to reinvent the wheel. We want to make use of the limited resources that we already have, but then rather expanding on the services that these resources can then provide, which is then the pharmacist. So this pharmacist would essentially need to be registered with Pharmacy Council of Namibia, where they would undergo some form of competency assessment. The training that is going to be conducted by the University of Namibia School of Pharmacy would expand over 9 months. And the reason for this is we're giving a longer period of time, because we know that a lot of pharmacists would not necessarily be able to attend such a course full time. They would need time away from work, but then also time to do the course. So it just makes it much easier in terms of work-life balance as well. And there is, of course, a standard mark that they would need in order for them to officially be recognized as a prescribing pharmacist. And this prescribing pharmacist would also be undergoing training in pharmacotherapy. This is related to clinical skills and patient assessment, and even advanced pharmacotherapy then now, which involves mainly also, or it will be zooming into the management of acute and chronic management diseases. So just maybe around 2 months back, there was a stakeholder engagement that focused on getting all the stakeholders, all the relevant stakeholders at one table to discuss what this prescribing pharmacist would actually be doing. And the regulators were also having questions, or also raised questions basically to the technical working group to say, is a prescribing pharmacist really needed? Is this not perhaps an encroachment into the job title of a medical doctor per se? And then there were also conversations around, do we regard a pharmacist as a clinician? And if we say a pharmacist is a clinician, is this pharmacist who is deemed as a clinician not then able to ensure that whatever services they provide should improve the patient outcomes? And where do we draw the line by the prescribing pharmacist knowing that, okay, whatever they're presented with by the patient in front of them is now beyond their scope of practice, and they would be professional and ethical enough to be able to refer the patient to the next level of care. So this is also very important, because as pharmacists, we also don't want to create an environment where some people would want to take advantage and then, be greedy in a sense, because we are there for the patients and we exist for the patients. So it's really, this program is really set up to be patient-centered. There needs to be professionalism involved. There needs to be a level of quality assurance as well, especially with the training that will be conducted. And the training that comes with the course does not end there. That's why the technical working group also then roped in the Pharmacy Council to say that you've got a component for continuous professional development. And in order for that to happen, if someone does this course today in 2024, in 5 years' time, what they learned in that course, would it still be relevant? Would it still be meeting the immediate needs of primary healthcare services within the private sector? And then there are also considerations to affordability, really looking at how expensive healthcare is within the private sector sometimes, it's just not feasible for one to always start at the tertiary level of care. Primary health care is important. And I think what really solidified the need for the expansion of primary healthcare services to the private sector, particularly the community pharmacists, was during the time of COVID. During the time of COVID, people could not get to every public facility in order for them to go and get their vaccinations. So then this is also where collaboration comes in, and private and public partnerships need to be strengthened. And we saw this during the time of COVID, because then the government was like, okay, for the people in the urban areas, they cannot all flock to the public facilities, because then they're waiting in long queues and they need to get back to work and everything else. So then how about we ask the community pharmacies to just serve as an appropriate setup? A nurse would be dispatched there who would be able to carry out all the necessary pre and post procedures for vaccinations and ensure that someone can get vaccinated in the pharmacy. So I think COVID really opened up our eyes as to what the possibilities are in terms of providing healthcare. And as an African continent, we also need to consider that if we're going to be speaking about expanding primary healthcare services, we need to look at our technological advancements. What do we have? When we're speaking about ensuring that the medicines that reach the patients are safe, then what structures do we have in place? Apart from then just saying that this prescribing pharmacist would be receiving this license in order for them to, prescribe or provide primary healthcare services in the pharmacy, there were also considerations to, can this license be given only to the individual? And that as Frida, if I'm a prescribing pharmacist, can I then use my license to be offering these services in pharmacy A and then as well as in pharmacy B? And if pharmacy B does not have the necessary setup for me to be able to carry out my services, does it mean that that pharmacy or that institution also then needs to be licensed? So these are some of the things that we were looking at. And then also in terms of mobile services and mobile clinics, if I decide that I'm going to purchase a truck and I'm going to equip it with everything that I need in terms of medicines as well as equipment and instruments and whatsoever, and having the appropriate reference treatment guidelines. If I'm to do that, what controls and measures would be in place to ensure that my services are not at the end of the day compromising the healthcare of the patients and the patient outcomes? So these are some of the things that we have been looking at, and the stakeholder engagement was just the first foot in the door, and it seems to really be positive. And basically now it's just something that needs to be presented to the officials of the regulatory bodies so that we can see how exactly to move it forward. As a country, we also are then, as little of a population we have about 12 to 13 indigenous languages. So then there is also that consideration of providing primary healthcare services in various parts of the country. It means that you would also want people who are qualified, let's say pharmacists who are qualified and speaking various languages in order for you to be able to cater to majority of the patients. So that's also something else that we are looking at. So in terms of laws, regulations, and policy, we have that. It's now just the framework that needs to be set up in such a way that it can facilitate the implementation of these services that we wish. And but I would like to say I'm glad that we're all facing the same challenges, because then at the end of the day we'll all come up with the same solutions as well, and then see really what works. And we divided up. I mean, as a country, we also needed to look at what is the situation in sub-Saharan Africa. We looked at Botswana, we looked at Zimbabwe. What does it look like in South Africa? So when we borrow certain solutions from our neighboring sister countries, and then we can see what works, what doesn't work, then we can expand it to the continent, and then also what's going on in the world. So from my side, I would like to say thank you very much, and I look forward to a lot of more questions as well, and to see what everybody else is dealing with. Thank you.
Thank you so very much. Wow. I'm so glad that you're here, because some of the inputs that you have, some of the perspectives that you have provided to this conversation is, I can say, maybe out of the box for some of us. Many of the countries, having the law already stated and in the favor of all the healthcare providers within the boundaries of that country is something that many countries do not have. So excellent. Thank you for being here, and thanks for the perspectives that you have shared. We'll be taking it on further in the open discussion, but before we go on to the open discussion, we have our third discussant for today, and she is no other than the president of the African Pharmaceutical Forum, the 6th Regional Forum, or 5th, depending on how you look at it, of the FIP. She's the MD CEO of Nufifi Avenue Pharmacy in Zimbabwe. She had worked as a hospital pharmacist during her internship and was appointed course supervisor and lecturer on the pharmacy technician training course. She has been in community pharmacy practice for over 20 years. Pharm Chiba has served as president of the Pharmaceutical Society of Zimbabwe, chairperson of the Community Pharmacists Association, CPA, patron of the Zimbabwe Pharmacy Students Association, and she's been an APF Exco member and FIP Council member for a bit. She served as board member of the Pharmacists Council and Medicines Control Authority in Zimbabwe for over 15 years, or for the past 15 years. She holds an MBA, PGD in clinical pharmacy, PGD procurement and supply chain, and a postgraduate certificate in clinical HIV, among other qualifications. Please join me as I welcome Pharm Chiba to share her perspectives. You have the floor, ma'am.
Right. Thank you, Arinola. I don't know whom we are talking about. Sounded so brilliant. Anyway, thank you for the invitation to this webinar, and just to share what I've come across in terms of pharmacy practice within the region and within our country as Zimbabwe. When Dr. Mohammed was talking about the expansion of primary healthcare services, what came to my mind is the fact that the pharmacist needs support staff to be able to provide these services, but the support staff as well should be trained. So you need a pharmacist who is adequately trained to be a supervisor for their subordinates, and the subordinates who also know what they are doing. So the training is important. And also for pharmacists, continuous professional development is key, because when you look at pharmacy and medicine, they are very dynamic fields. Things are changing. And as such, we need to keep up to date with that. And when we look at a pharmacy practice and what pharmacists can do in terms of provision of primary health care, I see pharmacists as well positioned in their community pharmacies, for example, to be able to provide services. There's no need for an appointment, and you can provide confidential services. Someone can walk in at their own time without an appointment, and at any time of the day, as long as the pharmacy is open. So it makes the pharmacy and the pharmacy personnel very accessible. And this is an advantage for us to provide primary health care. And in most instances, when they come in for consultants, so far, in most places, the consultation is for free. And that gives us an opportunity to say what we want and help the clientele who walk into our pharmacies. So from what Dr. Mohammed was talking about, in terms of training and in terms of what pharmacists in community pharmacies can do, we have a very big opportunity as community pharmacists. It is feasible for us to provide services in different ways. Sometimes a patient can go to the doctor. There's not enough time because, or the doctor is more scary than the pharmacist. I don't know. That's just my perception. And pharmacists tend to be more communicative. And that's an opportunity where you can provide advice, both for chronic and non-chronic medical conditions. But of course, whenever you want to change, there's always resistance. And it's usually not from the other people. The pharmacists themselves may not want or may not feel confident to change the way of doing things. So I think that is the first port of call for us as pharmacists to know our position, to realize how much we can do to change the way of doing things. So in terms of feasibility, it has to start off with the professional pharmacists themselves, in their position and positioning themselves to be able to carry out the changes required. Research in other countries have actually shown that pharmacists are very much trusted healthcare professionals. They are confidential, they know what they're doing. As long as we take our role seriously as pharmacists and not just want to just dispense without giving adequate information to our clients. And then but my problem or the challenges which I see, first of all, is ourselves, not being confident with ourselves. But I think that can be overcome, maybe through training, more education, especially not post-grad, but a continuous professional development and continuing education so that we become more confident and whatever is coming on board, we'll be able to present that. Some of the expanded services which have come in the recent past, especially with the COVID, we have pharmacists who are now administering vaccines. But we also have pharmacists who are scared to administer vaccines. But those who are not scared, with adequate training and support in terms of policy guidelines and legislation, I'm sure we can go a long way in providing that primary health care service, because vaccination is a primary health care thing whereby we are administering vaccines to people who are not sick. So that's a primary health care role, which pharmacists should embrace. And then we have things like PrEP and PEP. PrEP, which is a pre-exposure prophylaxis and post-exposure prophylaxis with the ARVs, antiretroviral medicines, in the prevention of HIV transmission. Pharmacists can also do that. They are accessible, available. They should be available. But the challenges which I've noticed in most of us, in most of the countries, which have also been stated by the other speakers, is the lopsided distribution of the pharmacy facilities. The same is the similar situation in Zimbabwe. You find that the pharmacies are in big numbers in the urban setting. And in Harare, where I'm based, you can find a pharmacy around every corner. Then as soon as you leave the urban centers, there are no pharmacies. The people have to rely on government institutions like the clinics and so on. And as such, we have not been able to go out into the rural areas to save our rural communities. The challenge there may be something to do with feasibility and sustainability of the pharmacy business. Sorry, sustainability, that's what I'm looking at. The pharmacy business in those settings. And in my mind, maybe if we've got a primary healthcare setting and there's a policy by the pharmacies and government and even the national health system is able to support the pharmacy to be able to be opened in those areas, then you have a sustainability, you improve sustainability, and pharmacists will be able to penetrate in those rural areas. Maybe in different levels from what is happening in Nigeria. They've got the other lower level, which I believe is not a community pharmacy level, but like a distribution center, a lower level, a cadre. So, but it also requires the legislation, which my previous speaker alluded to, that the advantage in Nigeria is that the Pharmacy Council is the one which has taken the lead. In Namibia, it's the Pharmaceutical Society, which is trying to lobby with government and the Pharmacy Council. And here in Zimbabwe, we don't have such a setup. And our legislation as it stands right now requires a pharmacist to open a pharmacy. So in itself, that's a challenge. And to sustain the pharmacy business there, it becomes a very big challenge. And also now, when I look at this issue of what pharmacists can do, on Saturday last week, our Pharmaceutical Society of Zimbabwe, they hosted a meeting or a panel discussion from the various practitioners on how we can extend services. There was input from the community pharmacists, what they think they can do, and the wholesalers who actually bring in the products into the country, either by importation or they supply from local manufacturers. So each one of these people can do something to improve access of medicines to the raw setting. But of course, as I said earlier on, the cost is one of the major things. Because even to open a pharmacy, we've got so many licenses which are required, and that is not cheap. So that can be a setback. Then when it comes to manpower development, the human resources, the pharmacists themselves, there's a continuous professional development, and the institutions of higher learning, the curriculum should also be addressing at the practice which we intend to have to ensure that pharmacists are empowered to give that, and even the cadres who are support staff, like pharmacy technicians. We also have what we call dispenser assistants here in Zim. How adequately trained are they to support this whole thing? So at the end of the day, there's need for collaboration between policymakers, the educator, those in practice, and those in practice themselves should have confidence to provide that service, and should also take the bull by the horns by going out and lobby with the policymakers for improved quality service, and ensure that this is what we can do, and this is where we are lacking. The educator, can you please be involved and educate us in these areas so that we're able to provide adequate service? I think for now, I can stop here. Thank you so much.
Thank you so very much, President. Madam President, a couple of things that you mentioned that we will take on in the open discussion, including what I call regulation or over-regulation of the pharmacy practice, mentorship, the issue of confidence by pharmacists, and the need for training, as well as mentorship. If there are people that people see as role models that are confidently carrying out these clinical services, it may serve as a means of improving their own confidence as well. Okay, so we're going on into the open discussion, and we have a bit of time to look at the questions in the chat box, as well as any additional questions that may be coming forth at this time, as well as to do some kind of open discussion around some of the issues that have been raised. I will just start with the question that I have tagged to be responded to live on the chat, on the question and answer box. So Ignacio is asking, and I apologize if I didn't pronounce the name well, how can including prescribing pharmacists in the African region enhance primary healthcare delivery and patient outcomes? Dr. Mohammed, would you like to answer that question, or would you like to provide some perspective on that question? Dr. Mohammed?
Yes, please. You said, how can including prescribing pharmacists in the African region enhance primary healthcare delivery and patient outcomes? It will definitely help in enhancing primary healthcare delivery and patient outcomes, because if the policy for pharmacists to prescribe is entrenched in any system, it will help to upload certain workload on the physician. Because if you go to an average primary healthcare center, you see almost hundreds of patients waiting to see the physician. And the physician will end up not seeing all of them. But if some of these tasks are shared with the pharmacist or shifted to the pharmacist to prescribe certain category of medicines for certain categories of disease condition, it will help to address the workload on the physicians, and thereby patient outcomes will be enhanced, and the primary healthcare delivery will definitely improve. Because a lot of patients are there to be attended to, but because of limited number of human resource of physicians in the rural areas, they are not there to perform, and the patient will come and go back, and some of them end up dying. So prescribing pharmacists will help to upload some of the workload of the physician, and that will help to address a lot of issues, and patients will be better off for it, and the patient outcomes will definitely improve. That's my little contribution to that. Thank you.
Thank you. Any of our panelists want to add to that? And while I'm waiting for somebody to, Frida's hand is up, just 1 minute, ma'am. So I just put it on the chat box. Please, you can put on your cameras now. We'll be taking pictures as we go on in this open discussion. There are quite a bit of us, so it's not something we can do at once. So please put on your cameras and we'll be taking the pictures as we move on. And then, of course, I know there are younger people here. So please, if you have dexterity in taking Zoom pictures, please, you can assist me in taking those pictures and then sending to me later. I will still try my best, but I find out that my best is not usually good enough, and then I have to manage it like that. So if you have dexterity, please go ahead and be taking pictures frame by frame so that we can share that as we go on. Frida, please go ahead.
Yes, thank you. Let me maybe just, should I still keep my video on? Sorry.
Yes, except if it's disturbing your bandwidth.
Yeah, I think so. But just in addition to what Dr. Mohammed also said, essentially the pharmacist, if you just think of it, the pharmacist actually has time on their hands. The physicians normally do not have that much time on their hands. And when I spoke about there also having to be a referral system, just shows that it needs to be a collaborative effort. It's not only my patient, it's our patient. So in terms of the more complex medical treatments, one would want to leave that to the physicians, but let the pharmacist deal with just the beginning of the disease management and the patient outcome management of this patient. I think that is quite important for us to take into account, because they also cannot do everything. And remember, where pharmacists are available, there might not be a doctor available. Also, in terms of cost, the medical doctors, I'm not sure what the setting is like in other countries, but definitely seeing a medical doctor is much more expensive than it is to see a pharmacist, which is your primary point of care. Also, as pharmacists in Namibia, we don't charge for our time. You can come in and tell me your entire medical history, and we don't charge you for that. I'll spend 30 minutes with you, but the doctor cannot afford to spend 30 minutes with you. It's 10 minutes. Tell me what's wrong with you. I'll give you the appropriate medication. If there needs to be any additional tests that need to be carried out, I'll do that. But for now, let me just do this. But we are also the experts on the medications. We are also able to carry out medicines use evaluations. We're able to look at whether the current treatment that the patient is on is leading to polypharmacy, or there are very, very dangerous drug interactions. These are things that we actually have time for because we are trusted. And really, we are trusted, as Dr. Joda and also Dr. Jocelyn said. So we are filling a gap. We are filling a gap. There is a gap we've identified, and we are filling it.
Thank you. Thank you so much. I'd like to add to that. And an interesting thing that popped into my mind on this issue of prescribing pharmacists is that we may look at it from a point of research and see what the generality of pharmacists across the continent think about pharmacists being provisioned to prescribe whatever level of prescription that it is. You know, we could do a joint study across the region and do a survey to find out what we think. Because one of the points I penned down for our open discussion is that some of the pushback is not even coming from outside the profession, it's coming from within, from fellow colleagues, and Jocelyn mentioned that earlier, from pharmacists that are like, oh, I am comfortable where I am. Why are you trying to give me more work? Or why are you trying to task my comfort zone? Or why are you trying to threaten my retirement with all this issues that is causing challenges in the workplace? So I think that as a continent, we may be it may be good for us to do some joint research to see what is going on within us as a profession, and then we could then use that as a means of talking to ourselves on why it is necessary. I know all of us will not move at the same pace, but that if there is a critical number, a good number of us that is able to provide this additional clinical services with enthusiasm, with vigor, then we should take that on as a continental project and then push it from that point, maybe through the APF or through the Association of Schools of Pharmacy in Africa that is soon to be established, and then see how we can get that on as a national thing. Because sometimes what people think should be important to us may not actually be what is most important to us. It is trying to sort out the things that is causing us as professionals, as pharmacy professionals, to prevent other pharmacists that want to provide this service from doing so, especially if the person that is preventing you is your boss. Then there's really not much you can do as maybe a younger pharmacist or a lower level pharmacist in an institution where your boss has said that, why are you doing that? What is the purpose of that? Or you're trying to take the shine off me in this department, or you're trying to be known with the doctors while the rest of us are not. So some of these things we may want to look at it from that national angle and see how we can take it from there. Thank you so very much on that point. Another point I want us to discuss on this open forum. Okay, there's another question that I put from additional. She says, my question to Farm Joyce, and she has indicated who she wants to answer this question, is to ask, and that's Jocelyn, to ask how the community pharmacists offer PEP and PrEP, especially PrEP, knowing that the basic investigation of kidney function must be done before offering the service. Jocelyn, over to you, please.
Thank you so much. I always like that question when people ask me about adverse events and adverse events monitoring, which is part of pharmacovigilance. And when we're talking about PrEP and any other medicine for that matter, pharmacovigilance is key. And I just was wondering how many physicians are doing kidney function before they initiate PrEP to their patients. But it always comes to pharmacists how are you going to deal with this one? I'm not trying to downplay the question, but what I'm trying to say is that there should be a policy whenever you are looking at any treatment method or any medication you're going to give. So if it involves like point of care tests, that could actually be part of that PEP and PrEP. When I look at, especially those who are coming in for pre-exposure prophylaxis, they should be HIV negative. That's point number one. So even that test should be done before the patient is even initiated on that. And the same thing would also happen with the post-exposure prophylaxis. You are looking at the HIV status of that patient. And when they've taken it, they should also come for a point of care test, and the confirmatory test should also be done. And the same thing can happen with the renal function test. There are tests which can be done, and this should be part of the policy treatment guidelines whenever you are coming or introducing any new treatment medication. Even, it's not just PrEP, it's not the only one which comes to my mind. Even when we initiate, contraceptives, you have to ask certain questions so that you can get the medical condition of the patient. Is the patient hypertensive? How do you know? Measure their blood pressure. Are they diabetic? Measure their blood sugar. so that we have those questions which can actually eliminate some of those basic medical conditions which can be contraindicated in initiation of any medication for that matter. And when I talk of PrEP and PEP, that's a primary healthcare issue because we want to prevent disease progression in your patient or prevent them getting an HIV infection. So that's the way I usually look at it whenever it comes to introduction of any new medication. But of course, there's, for us in ZIM, currently, those medications are on prescription. So there's also need for that regulatory and policy guidelines to be used so that medicines can be classified as pharmacist initiated or as PP and so on as we get along. I think that can start the debate going. Others can add on their thoughts. Thank you.
Thank you so much, Jocelyn. Frida, I thought I saw your hand up. You wanted to comment on that?
Yes. I think there was also just a question about what incentives are then available for pharmacists that are doing this. And I think, Dr. Arinola, you already touched on it. What I am seeing and sensing is that much of what we are talking about today is already being done by a pharmacist. There is just a lack of legislation and law. There's a lack of a training framework that will assert quality assurance of what we want to do and ultimately the patient outcomes that this will result in. So when we are speaking about these primary healthcare services and expanding it to the private healthcare sector, let us remember that currently within the private healthcare sector, you've also got the medical insurance or medical aid funds companies, right, that already are able to claim, you're already able to put through a claim for a specific ailment because of ICD-10 coding. And so if a primary healthcare service is to then be expanded into the private healthcare sector, particularly a community pharmacy, then with the evaluation that you're going to do to determine that, okay, after carrying out this specific test, I can then now classify that the patient has so-and-so ailment. And this ailment can be classified according to ICD-10 coding as such. And then you will be able to claim for that service from the medical aid and be able to pay for that. So that is an incentive on one hand. On the other hand, it's just generally God's work. It's contributing to patient healthcare because when you ensure that your patients are healthy, they're on the appropriate treatments, and you are watching out for adverse drug reactions, like Ms. Jocelyn said, you're ensuring a productive population for your country, essentially going to be contributing to the economic development of a country. So I mean, we shouldn't be thinking about this also in a box, right? And we should just know that this the expansion of these services should be something that should be done collaboratively and holistically. It's not that pharmacists now want to come and bulldoze and we want to claim our or make known our position in society, but it's something that we're already doing. We just want some form of recognition for it, the way other professions do, but also to say that we exist here for the patients and we really bring our side in terms of providing the best healthcare services that we can. But there needs to be some recognition for it. And I'm not saying that this should be now a motivation for us to push forward for this, because there are multiple benefits and outcomes at the end of the day. But it's also just to say that if you feel that you're already doing this, how would that motivate other people? And let's keep in mind that as an African continent, maybe some of the struggles that we face is also having students that are pursuing pharmacy within the country or from outside of the country, that they need to come back home. And then as pharmacy councils, we wonder, where are we going to exactly put these pharmacists once they have now attained their licenses to practice, where they're going to go? So part of doing this is also expanding the scope of practice of a pharmacist, expanding the current clinical practice of a pharmacist to be able to do just one more thing apart from just working in a hospital ward, for example. So we need to be thinking more broadly in that aspect, that there's so many benefits, not only for us, but as well as the patients. Thank you.
Thank you so very much. And my next question goes to you. And if there are any more questions that the audience have, please go ahead and ask them. So my question, I'm going to start with you, and then go on to Rana too. I hope she's still there. It's on the trainings. You mentioned that in Namibia, the law is very much captured. The law is the law is there, which is not the thing in many other African countries. Now, these trainings that the task force is advocating, who is responsible for bearing the cost of that training, and who is responsible for training these pharmacists that want to engage in these activities already covered by the regulatory by the legislation that you have. You know, pharmacists that are already practicing, and you now want them to be trained, because definitely nobody is going to say, oh, because you're a pharmacist, you can now just be a prescribing pharmacist without appropriately training you for that service. You know, so is that training being borne by the individual pharmacist? Is there a means where the regulatory body is involved, or is there something that the pharmacist society is contributing to the profession? I was just interested in that bit of your presentation, Frida.
Yeah, thank you, Dr. Joda. So this course would be just one course at the moment, and it is specifically developed by the technical working group, but the custodian of it would be the University of Namibia School of Pharmacy. So they are then the course development team, and they are responsible for setting up this course, which will essentially be called Primary Healthcare Prescribing for Pharmacists. And as I alluded earlier on, that this course would specifically be targeting registered pharmacists in Namibia. And these registered pharmacists in Namibia would be then doing this course for about 9 months, right? And the framework for this course was basically presented to the regulators, and it is a very comprehensive framework, and the regulators just had to say yay or nay. They had to say that, okay, we have looked at this framework, we are satisfied with it, that at the end of the day, it really does determine and allow for the assessment of competency of this pharmacist who wishes to prescribe, because it's already provided for within the law. And so there is definitely a criteria even for admission for these pharmacists. Within the pharmacy degree, a normal B.Pharm degree, you already have some exposure to primary healthcare or basic clinical skills that you're supposed to undergo. And so that's essentially how it would be. Maybe I missed the last part of your question as well, Dr. Joda. Can you just repeat that one?
About who is responsible for the cost, bearing the cost for the training?
For the cost, okay. So essentially, the pharmacist who would want to prescribe is responsible for carrying this cost, right? Because it would be something in addition. It would be an additional qualification, actually. We would want it to be recognized as an additional qualification. So they would have to fork out the finances to fund it. The cost is not yet determined at this particular moment in time, but it would not be too expensive, looking also at the benefits that it could be providing for. So yes, the individual pharmacist would need to cover the cost. And based on our regulations, so in our Medicines and Related Substance Control Act, this person would not just be called a prescribing pharmacist. They would be deemed a Section 31(2) licensed pharmacist, because that is the provision within the Act that allows for them to carry out this specific function.
Thank you so much. Thank you so much, Frida. Rana, one quick question to you. And you mentioned the issue of the landlocked nature of Niger, and that most of the pharmacy services is in one aspect of the country. Now, if how can, maybe would I say, an African Pharmaceutical Forum, or if our proposed Schools of Pharmacy in Africa, the Association of Schools of Pharmacy in Africa, how can that organization, for instance, potentially assist Niger in building capacity or increasing the number of pharmacists available for pharmaceutical services in Niger? What are your thoughts on that?
Well, thank you, Joda. For the meantime, we have a pharmacy school that opened, and I think they are at their third graduation. But the problem with French-speaking country and Anglophone-speaking and English-speaking country is the problem of certificate. There is a language barrier and there is the problem of certificate. Even though now in Nigeria, they are no more doing the BPharm degree, but those of us that had the BPharm degree, we've started having challenges because they are considering us not to be pharmacists.
Oh, wow.
Because of the population bachelor, they just want to hear doctor. That one is one of the challenges, those that went to English-speaking countries for their pharmacy studies.
Yeah.
But I think with what I saw at the Eco Akete 2024, it gave me some ideas on how to really cooperate with Nigeria.
Okay.
And even if we are going to take translators to try to see how we can organize some trainings, because even the fact that there are not a lot of pharmacies in the regions, those that are even in Niamey are not doing some continuous training. So maybe we will see with you people and the Clinical Pharmacy Association of Nigeria how to organize some continuous trainings to improve the level of practice in Niger.
Thank you so very much. We have 5 minutes, about 5 minutes to the end of this webinar. And I'm going to assume that I have taken the last thoughts of everybody, of all the panelists in the webinar. I somehow not able to take pictures because it's only the panelists I can see their video. So I hope that the FIP office has been able to assist me in taking that picture. But just to be sure that I'm sure, panelists, please put on your videos again because I can't see the rest of the participants. So let me just take that so that I'm sure I have taken something that we can put on the APF side. You know, so as part of my announcements, it's just to say that we know that FIP and the one FIP strategy of FIP is now very much on ground, and with the integration of the forums into mainstream FIP, we have that all our structures are now being integrated properly with FIP. And so our logo is changing, our website has changed, and we're able to, we're going to be found properly on the FIP website. You know, so thank you very much. You can put up your videos now. So let me just quickly share the screen to be sure of the other announcements so that I don't miss any. Sorry, just 1 minute. 2 minutes, 2 minutes ago. So we've done that wrap up and conclusions. Just a quick reminder that this webinar will be on the FIP digital event site, and you can scroll down when you get to the events.fip.org website. You can scroll down to get to the topic of interest for this webinar to listen to it again. As we know, APF is very much on ground, and our first Sub-Saharan Africa FIP conference is holding in just about a month's time in South Africa. And we're all very much invited to be there, innovating for the future of healthcare. APF will be 20 years, this FIP. Well, 20 years already in April or May, actually, but we are planning to celebrate 20 years of APF with a meeting and then a small reception on Tuesday evening during the FIP Congress. That's on the 3rd of September, so you're all very welcome. If you are having any challenges, for those of us that are planning to be at the conference, if you're having any challenges with your visa, please do reach out to me so that we can reach out to our friends in South Africa to help resolve the issue. And we're hoping that we'll see all of us in the Congress in a few weeks' time. Just to be sure that we have captured everything. So I think I only have time for one comment by our guest speaker. Dr. Mohammed, please wrap up on behalf of everybody before we close out.
Yeah, thank you very much. And what a wonderful and interesting webinar. I also want to say that the essence of this all is to see how to reposition the community pharmacy in the healthcare delivery. And I don't know if in most of the countries, most especially Namibia, whether the community pharmacy has been officially recognized as primary healthcare providers. If it has not been done, I will advise that a deliberate policy should be made by the Federal Ministry of Health. This will help to open door for other things to come. And the recognition of community pharmacy as primary health provider, we thereby transform them into service providing center rather than just being product provision centers, thereby transforming from product center practice to service center practice. That is the core of the whole story. Once they are now recognized Federal Minister of Health of Uganda came with a team to come and understudy all these things we have discussed today and to see how they can be implemented in other countries. I would therefore wish to advise those of us who are listening to go through whatever we have discussed and see how the community pharmacy practice can be improved and integrated as a primary healthcare provider. And that will be a very big step ahead of integrating the pharmacy, the community pharmacy into the healthcare delivery system of the country. Thank you, and I wish you all the best.
Thank you, everybody. And of course, the discussion can continue even after this webinar. You can reach us on the APF email, and I would be reaching out to as many people as would like, not, because we have a general APF WhatsApp platform that I know many people are not on. So you can reach out to me with your number. I can add you there, and then we can take on the discussions even from there. And of course, through the APF and the president of APF, ideas for collaboration, for integration, and of course, this idea about a research collaboration, we will take it on further thereafter. So thank you very much, everyone. It has been very lovely having all of us at this webinar, and thank you for attending. Hope to see all of you in Cape Town. Bye-bye, everybody.
See you in Cape Town. Thank you.
See you in Cape Town. Bye-bye.
Bye-bye.
President, I ensure that you bring a lot of goodies for us to celebrate.
Not only President, everybody should bring something.